maybe I'll start the process by asking Dr. Vonderheide about the recent approval of CAR T-cell therapies and how you think this is going to be expanded or relevant beyond leukemia.
So thanks, Leena. And good morning, everyone who's here and maybe watching online. Is that what people do now, I guess? Great way to get information out. So I'm at the University of Pennsylvania Abramson Cancer Center. I became director of that cancer center 2 months ago. And then within 6 weeks, the FDA approved this new cell-based therapy on last week of August for acute leukemia, as Leena was describing. And what a way to start and to just really think about the impact of what happened. And so I think it's a game changer. We've been seeing lots of progress with immune therapy. This particular therapy is, as Leena described, is essentially a white blood cell transfusion. This particular one that was FDA approved was developed at Penn, but there's many other versions that are coming. And I think we're going to see many, many FDA approvals over the next few months for different types of cancer. I think the next will be lymphoma. And I think it represents a completely different way of treating cancer. And I think from not only this therapy, but the other immune therapies, things will never really be the same again in how we approach and treat patients with cancer, which is a wonderful thing. This has, it came upon us. It was great news. And some people have criticized the hype around it, actually, some of our colleagues. And I think it's important to remember, as we think about the 60 years that the CRI has been in this business, that what happened with that FDA approval is really a 20-year overnight sensation. It was based on research and understanding what T-cells do. And it wasn't just a guess. It came from a lot of hard work and patient participation in clinical trials. So we're very hopeful of what it means now going forward. Can we use this type of cell-based therapy to treat patients earlier? Can we use this therapy to treat patients with other types of cancer, breast cancer, pancreas cancer, brain cancer? And it's really tantalizing and an incredible opportunity that we have now in 2017. I would just finish by saying I think we need to be realistic about what's going on and what it represents. As great as the excitement is and really taken us all by storm, we need to recognize the limitations, right? So right now it's really only approved for young adults and children with a certain type of leukemia. That's it. Of all the types of cancers, it's a very small number of patients for whom this therapy is available. So that has created the challenge, can we move this beyond just those tumors into other tumors? But also, the treatment does not come without toxicity. So there's many side effects about that, and we need to manage those. The day the FDA approved this therapy, they also simultaneously approved another antibody to treat patients who are having a side effect from that therapy, which I thought was actually pretty clever. And so that's available, but there's a lot of work to be done. And finally, the cost is exceedingly high, one of the highest that we've seen, about $450,000 for a single infusion. When it works, you only need one infusion. And so we have to come to grips with that as a country, as our institutions, and as we talk to our patients. So, but there's great inspiration to tackle all those challenges because of what it represents by itself and in combination with all the other great advances that are happening.
Thank you. Maybe I could kind of go to the other end and ask you, Dmitriy, if you could comment on where do you see the future of immunotherapy, CAR T-cells, PD-1, other things? What do you think the future?
Sure, absolutely. So my name is Dmitriy Zamarin. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center. I primarily treat patients with gynecologic cancers, but also participate in phase 1 immunotherapy trials in patients with different cancer types. So as Dr. Vonderheide and Dr. Gandhi have mentioned, we have seen quite a few approvals over the past few years with many of these agents, including what you call immune checkpoint inhibitors and the CAR T-cell therapies. So the question is, where do we see the future in these things? So the reality is, I'd like to emphasize, is that there are quite a few patients that do benefit from these drugs. and those benefits tend to be pretty durable, but we obviously would like to extend this benefit to many more cancer types and many more patients. So for example, for gynecologic malignancies specifically, there are not as many patients that respond to these drugs. So the next answer is really going to be in the combinations as you have described in your talk, there are many possible combinations to pick from, whether we combine things with chemotherapy, immunotherapy, or new drugs, radiation, and all of these trials are currently ongoing. And I think the key is really going to come down to really us understanding what is it about the specific patient that's different about their immune system from the other patient that would allow us to pick out the specific therapy for that patient. So, for example, we know that endometrial cancer, for example, this is one of the cancers that I treat, the responses to immune checkpoint blockade are not that high. In general, in a population, it's on the order of 10 to 15% of patients that can actually have their tumor shrink from this therapy. But we know that a subset of these patients with what we call MSI high cancers that Jill has referred to earlier, and those are the patients that are characterized by many mutations in the tumors, they can respond very well to these treatments. And we know that the drug called pembrolizumab was recently approved specifically for patients that have these sorts of mutations. So for us, in selecting the right type of treatment for the patient, we really need to understand what is going on with their tumor, and hence this is one of the tests that we do now on all of our patients with endometrial cancer. We stain their tumors to understand, do they have this high mutational load? Do they have these specific biomarkers that would allow us to select this sort of treatment? And I think that's where the future is going to lie. I mean, we're still very early on. It's still hard for us to understand which are the patients that are going to respond to even a single drug. And you can imagine how complicated it is going to become when we try to understand, which is the patient that's more likely to respond to the combination. But we're well on the way there, and hopefully we'll see some great responses and great results with this even as soon as within the next year or two. Yeah.
Thank you. Yes, I agree that's a really important point about that. This MSI high or high mutational burden is a common theme among all cancers that seems to be predictive in many different settings. Can I ask you, Michael, to talk a little bit about the side effects of these therapies? Because I didn't get into that. I think we've talked about all the excitement about it, but what about the side effects, and can you tell us more about them, and how do you think is the best way to manage them? What do we need to learn more about?
Absolutely. So hello, everybody. My name is Mike Postow, and I'm a medical oncologist. I work at Sloan Kettering Cancer Center on the Upper East Side here in New York City. And I see patients with melanoma, and like Dr. Zamarin, I also work in a clinic where we see patients with lots of different types of cancers in early phase clinical studies of new immune therapy drugs that haven't been tested so much just quite yet. Side effects from immune therapy are an issue. And unfortunately, when we turn on the immune system, which is the goal of all these drugs, the goal is to turn on the immune system, wake up our own bodies to the cancer that's there, and hopefully the goal is that immune system that's been turned on will seek out the bad cancer cells and destroy them, and that's the goal. But the problem is the immune system sometimes can be turned on a little bit too much. And as smart as we think the immune system can be to go around and just try to kill the bad cancer cells, normal healthy tissue can unfortunately also be attacked by the immune system that's turned on too much. So some of the side effects that we can see include some excessive autoimmune-like reactions against normal healthy tissue. Now, what does that really mean? That means some people could have an itchy rash. Sometimes people's lungs can be a little bit inflamed and cause a cough or some shortness of breath. Or sometimes people will develop some diarrhea from these treatments. The good news about most of these side effects is that they are completely treatable and usually in almost all cases reversible with temporary courses of immune suppression. So taking drugs like corticosteroids, like a prednisone pill, can sometimes help lower the inflammation back down a little bit so that people can feel better when they're on these treatments with these immune drugs. Hopefully we will have more immune therapies that move forward that are even smarter types of immune therapies that don't have as many side effects against normal healthy tissue and only turn on the immune system against the cancer cells specifically. We're not quite there yet, but that's a very interesting area of research. And we're also trying to find out what are the best types of treatments for immune therapy side effects. We have been giving patients steroids for a long period of time, but we heard now that there's an antibody that can be used to treat some of the side effects from CAR T cells. There are other drugs that are used for patients with autoimmune disorders that might be something that we could think about for patients with cancer that are having immune therapy side effects. And that's the kind of research that we're still needing to do. We're still needing to try to understand who gets side effects and who doesn't get side effects. And it was actually a very interesting study that we had done at Sloan Kettering a number of years ago where we knew that patients had diarrhea with some of the immune boosting drugs that we would give patients. And we had a thought, I wasn't personally involved with this, but there was our group was involved in trying to look at the bacteria that were present in the colon, in the gut of these patients to see, is there something that's unique about the patients that developed diarrhea versus those that didn't develop diarrhea? It was actually very interesting that certain kinds of bacteria were associated with the likelihood of developing this diarrheal side effect. And that raises some interesting questions. Should people be on probiotics when they take immune therapy drugs? What about antibiotics? Could we kind of manipulate the different bacteria that are in the gut to try to understand why some people are developing colitis and others aren't? And these kinds of scientific questions are really important so we can really try to get to the underlying mechanisms of why these side effects are happening. And hopefully as we develop more immune therapy in the future, the side effect risk will be even lower than it is.
And did you want to say anything about, do you think there's a relationship in any way between the risk for side effects or getting side effects and chance of benefit?
So the question is there some association between side effects and benefit from immune therapy? And this is something that's very controversial. I think it differs from different types of cancers and depending on the studies that you look at. So I don't think the message is perfectly clear, at least in my opinion. And I think it's a very hard concept to really study. One of the messages that I'll be very clear about is that patients don't have to have a side effect to have a benefit from this treatment. So the no pain, no gain kind of philosophy is not necessarily true for immune therapy. It can absolutely help even without having a side effect. So, I've had a lot of patients that are seeing me a little bit wondering, I don't feel anything. I feel totally normal. Are we even, are we doing anything at all? And then we get CAT scans and we see the tumors are shrinking or everything is looking good. And that's very exciting, but it doesn't have to come with a side effect. And so if there are side effects, they can be treated. You don't have to have side effects to have a benefit. And there's a lot of controversy on some side effects in association with benefit. I do think there are some side effects that are a little bit more clearly associated with benefit, at least in melanoma. One is what's called vitiligo, which is a whitening of the skin or eyelashes or eyelids. And that can cause it's basically due to an autoimmune destruction of the pigment-producing cells in the patient with melanoma when we give immune therapy drugs. And that does seem a little bit more associated with likelihood of benefit, but it's not required to benefit.
Thank you. And I'd like to maybe ask each of you a little bit more about clinical trials in the era of immunotherapy. Dr. Vonderheide, you run an entire cancer center, and both of you, I know, work in phase 1 clinical trials. I do as well. Can you comment about how clinical trials have changed in this era? Specifically, what I was thinking about is one of my colleagues who's also in thoracic oncology has long-term been a basic scientist who studied drugs in mice and combinations of drugs in mice, and we use that to inform general clinical trials. It seems he sort of moved away from that because we know that, especially in the era of immunotherapy, sometimes we can't always predict from a mouse what's really going to happen in a patient. And we are, I think, getting a lot more patient understanding about how these drugs work and how they work together from patients themselves.
Well, I think it's a great topic on, clinical trials are mission critical for what we're trying to accomplish to improve the lives of our patients. It's the mechanism from which all the new therapies we talked about today have come from. And yet, in this country, for everyone diagnosed with cancer, fewer than 4% of patients go on a clinical trial. I study pancreas cancer and work with pancreas cancer patients. That number is true in that disease as well. 4% of patients with pancreas cancer go on a clinical trial, which means that 96% of patients receive the same therapy we've been giving for years, and we know what to expect, which is not enough. And so clinical trials are absolutely critical. I think over the last few years, to answer your question, things have shifted from clinical trials as a last resort to clinical trials as the first thing to think about. So rather than you've exhausted all the therapies and there's really nothing to do, let's try this trial. We still have trials like that, and they've been successful. What we're finding is that, particularly in immunotherapy, the time we want patients to, where we try to improve the immune system, is much earlier on. And that can be done in association with other standard therapies. We just started a clinical trial with CRI's backing for patients with pancreas cancer, where they receive standard of care chemotherapy along with 2 experimental therapies at the same time. So I think this is the promise we need to make to our patients, which is that if you come to us and if we work together, we will try to find tomorrow's therapies today and make them available as much as possible. Clinical trials are more complex than routine therapy, but they're an essential mechanism. I think they're changing to be less of an exercise. And I just finished by saying that patients who I meet who are considering a clinical trial will look to me and say, Dr. Vonderheide, I don't want to be a guinea pig. And so I'm not interested in this trial, perhaps. They might say that. And I'll say, you're not a guinea pig, you're my patient. And I'm going to take care of you, and this is what I think would be beneficial for you to consider. And we form a partnership, and I think that is those types of discussions that have been happening in the immunotherapy that have allowed all these great successes, and I think the new successes that are just down the road.
Thank you. Could I ask maybe you to come on to them too? I know you're working in phase 1 trials.
Sure, absolutely. And I would have to fully agree with Dr. Vonderheide. Unfortunately, many of the patients that show up in our clinic or even referred to our center are the ones that have already exhausted all of the possible lines of therapy. And in fact, they may be too sick to participate in the clinical trials at that point. And that's why I always encourage my patients to consider clinical trial options earlier on for many different reasons. First of all, many of the trial options may be less toxic than necessarily the standard chemotherapies. We know what to expect from this standard chemotherapies. And for patients that perhaps have not exhausted these standard options and have low volume disease, it is a time to try something less toxic, like such as immunotherapy. I mean, with understanding that they may have side effects, because the beauty about these immunotherapy drugs is that they can give you if not a response, they can give a pretty durable disease control, as Dr. Gandhi has described in her slides. So if you can really, maintain your cancer with this low toxic therapy for a very long time before going on to the more toxic chemotherapies, we would certainly prefer that for our patients at the least. Now, many companies are also understanding that the patients who have exhausted many lines of therapy are the sickest patients and cannot go on the clinic and prefer not to enroll these sorts of patients. So many of the trials actually are limited by the number of prior therapies that you can receive, which is understandably so. Again, we don't want to give a patient a drug for the patient just to progress within the next 2 to 3 weeks and be taken off the study, because first of all, it's unfair to the patient. They're not receiving therapy that's probably the most effective for them, but it's also unfair to the drug, because if a patient starts therapy and then has to be taken off within 2 to 3 weeks just because the cancer is growing, and we know that these immunotherapy drugs might not work right away, they may take some time to work, it doesn't give us a good enough opportunity to evaluate these drugs, and we may render the drug ineffective, where in fact it could have actually benefited the patient if only we had some more time to evaluate them. So I really would have to agree that no matter where you are in your treatment course, whether this is right after the surgery and you're just receiving what we call adjuvant chemotherapy, or whether this is for recurrent cancer and the next sort of treatment option is is chemotherapy or some sort of a standard approach, it's always good to inquire from your doctor that other clinical trial options that are available, perhaps not with your doctor, but in a center nearby, because again, you have to be as informed as possible. Having these sorts of meetings is certainly a good way to get some information about the things that are going on around there. It's not just searching on the internet, but I guess the doctor should be the primary source of information for this. Yeah.
Dr. Postow, do you want to comment on different phases of clinical trials and how that has changed maybe with immunotherapy?
Absolutely. So I'll just agree with my colleagues here, and I'll describe that clinical trials and concept, there's a lot of misperceptions, I think, that are out there about clinical trials, and I'll set that in the context of the question we're talking about, different phases of trials and how do we think about drug development. Many patients do worry about clinical trials because there's a thought out there that, well, maybe I'm not going to be getting the real drug, that there's something called a placebo, which is an inactive compound that's intended to mimic what the real drug would be, and that there's a thought that of what's called a randomized placebo-controlled trial where patients and doctors don't get to choose what they get, and some people get a drug and some people just get what's called a placebo. The vast majority of trials now do not have a placebo, so I'll be very clear on that. The vast number of trials, all patients are getting the active drug, or what we hope would be effective for the tumor type. So that's one kind of misconception I think that's out there in the world, that I might not even be getting a real treatment. Very, very few trials are done in that type of a way. In addition, there's a lot of studies that are only considered clinical trials because it's a combination of two drugs that haven't necessarily been done before together. But one of them might be really, really active already in itself, and then the trial is adding something else to something that's already really active. And trying to understand the differences of all of this is very important. So when we think about the phases of clinical trials, traditionally clinical trials have been termed phase 1 trials, phase 2 trials, and phase 3 trials. Phase 1 trials are usually the first time that something is being done for patients. That does not mean it's the first time patients necessarily are taking a drug, ever. Sometimes that's the case, but many times, like I had mentioned before, it may just be the first time a new combination is being tested. So we could have an FDA-approved drug in a phase 1 trial with a new drug for the first time, and it's called a phase 1 trial because it's the first time that combination is given. So trying to understand the details about that's important. Phase 2 trials traditionally are larger numbers of patients in those trials, depending on the kind of disease, usually at least kind of 40, 50 patients up to several hundred patients. And that's where we really start to try to see how much this drug is helping patients and what really we're seeing in terms of risk and benefit even more. Phase 3 trials are the latest phase of trials that are usually leading up to a drug's approval by the FDA. Phase 3 trials are often randomized, where patients or doctors don't necessarily have a choice of which treatment may be administered in the trial. But what's important is, even in these randomized studies, these later phase studies like phase 3 studies, physicians and patients have to have what's called clinical equipoise to go into these studies, meaning we don't really know what's better between treatment option A and treatment option B. And the vast majority of phase 3 randomized trials for patients with advanced cancer will still have active drugs in both arms. And we really don't know which one is better. And that's why it's very important to run some of these trials to really try to see how this all works. What we've seen with immune therapy is this phase 1, phase 2, phase 3 system that we've been using for the past number of decades in traditional drug development is being turned inside out a little bit now. Because we saw with trials with PD-1 and PD-L1 drugs and a whole bunch of other immune therapy drugs, we're starting with phase 1 trials. And if there are good signals of efficacy with very minimal side effects, those phase 1 trials are just recruiting more and more patients and growing and growing and growing. And it may be something called a phase 1B trial or expansion cohorts and such. And those trials are really growing and growing so rapidly that in some of these drugs have actually been approved by the FDA based upon large phase 1 type trials. So I think it's important, if you're considering a clinical trial, to understand what phase of the trial that we're in, phase 1, 2, or 3, but more importantly, understand what's known about the drug so far, what are the different options of the treatment within that trial that might be relevant for me, And then what is the schedule like and how will this affect my life? That's obviously very important because often trials do require a little bit more involvement with the care team because it's important that we study a little bit more thoroughly. And we're very grateful for all patients that have participated in all of our trials because this is how we make new advances. And it's a very courageous aspect for patients to sign up for trials. And all of the advances we have right now are because of patients signing up for trials. So as a researcher, we're very grateful for that.
Thank you. Well, since we do have this sort of world expert panel here, maybe I could ask each of you to tell us a little bit about your specific area of research and how you see that impacting the future of cancer care.
Wow, that's a big question. Maybe we should start at the other side, other side of the podium. Who wants to jump in first?
Oh, I have to keep talking?
I was going to recommend for the melanoma doctor to start talking because this is where we saw the earliest and most significant advances in immunotherapy.
Okay, you go first.
Many of us are building on the melanoma model, so maybe, perhaps Dr.
This is how we did it at dress rehearsal, okay?
Okay, so as a melanoma oncologist, it's actually very interesting in the melanoma field that immune therapy is often the very first treatment we give patients. So I started in the melanoma field in 2010, 2011, and at that time, it was really one of the first immune therapy drugs, at least in what's called the immune checkpoint inhibitor treatments, had just gotten approved by the FDA, called ipilimumab. That was March of 2011. So my specific research interest had been kind of right around that time when this drug was coming out. We had some interest in combinations with this immune therapy drug and radiation treatment, with the idea that had been borne out by a number of laboratories that if you radiate a tumor, you may have increased immunity against that tumor. So there's a lot of laboratory science that suggests that's the case. And we had seen a very interesting patient example where we had a patient that was on this drug, ipilimumab, and was not really responding as well as we would like to treatment. We radiated a tumor, and then tumors outside of that irradiated area started to shrink. That was a very interesting observation in just this one patient, but it led to this idea that we need to do clinical trials where we test combinations of standard anti-cancer agents like radiation treatment and immune therapy. So one of my research interests, and Dr. Vonderheide and the group at University of Pennsylvania have been real world leaders in this concept as well, from the laboratory side through the clinical trial side. But one of my personal interests has been getting trials conducted of combinations of radiation treatment and immune therapy drugs. And we're running a trial in melanoma patients with combinations of several immune therapy drugs plus radiotherapy to see how the effects of the different kinds of radiation we can give might affect the immune system in these patients, and to make sure it's a safe approach to go forward with. So that's been one area of research, and then the other area of research is in combinations of different immune therapy drugs, most notably combinations of checkpoint inhibitor drugs like ipilimumab, in combinations with newer checkpoint inhibitor drugs like PD-1 drugs. So trying to test how that can be given most safely and in different schedules. That's been an area of research, and we have some interesting new ways that we're trying to study the immune system in some of these patients as well.
Okay. I guess I will be next. So I work in the gynecologic cancer sort of field, at least clinically, but my laboratory research is a little bit sort of coming from a different perspective. So I originally trained not as a cancer doctor. I trained as a sort of an infectious disease doctor and a virologist. And in fact, I studied viruses for my Ph.D. and I always thought I was going to be an infectious disease doctor, but then sort of became more interested in cancer later on. And to apply my interest in infectious diseases and viruses, I started looking at the reports of how can we use viruses to treat cancer. And it sounds like a crazy idea, but maybe not as crazy today as it was even just a few years ago. So this started back in the 1800s. People would have spontaneous remissions from their cancers, usually hematologic malignancies, if they contracted some type of a virus infection. And there was actually a report in 1912 of a young woman who had metastatic cervical cancer. She got bitten by a rabid dog and received rabies vaccine, not for her cancer, but she just received rabies vaccine. And rabies vaccine is an attenuated rabies virus. and she had a spontaneous remission of her metastatic cervical cancer. So back in the early 1900s, people really had no idea what viruses were. They sort of had no way to culture them. But then in the 1940s, 1950s, with understanding of cell culture techniques, it has become possible to grow viruses up in culture and actually use them as therapeutics. So this spawned a lot of clinical trials back in the early 1950s of people just growing up viruses and giving them to patients. And they used crazy viruses like West Nile and hepatitis B and some of the encephalitis viruses. And some of these viruses worked, but unfortunately, many of the patients succumbed to diseases like hepatitis B, encephalitis, and so those therapies were abandoned right around that time, just because also this was a time for development of the more modern treatments, or at least modern at the time, meaning radiation and chemotherapy. And then the more we learned about how the viruses interact with the cancers, the more we have learned to understand that the viruses don't necessarily just directly kill cancer cells. But the more interesting mechanism by which they work is that they activate the immune system. They create the site of inflammation that allows the immune system to now, which was shielded from the cancer, it allows the immune system to now recognize these cancer cells and recruit more immune cells, which are now specific not just for the virus but for the cancer. So I started working on this, I guess, close to 12 years ago, and then again I quickly learned to realize that the viruses by themselves are not very good agents. I mean, they can activate some anti-tumor immunity, but they probably need some sort of a boost to make the anti-tumor immunity work better. So I went to, this was back, I guess, around 2010, I went to Jim Allison's lab. He is the person who developed the anti-CTLA-4 therapy, and I said, I want to experiment with these type of viruses in combination within the context of this immune checkpoint blockade. And Jim was not very open to the idea, but he said, okay, you can do a few experiments. And then it turned out to work very well. It seems like when we take each therapy by itself, which might not be as effective, at least in the animal models, and then we combine the two, they produce what we call synergistic effect, meaning that the sum of the two is better than we would have expected from each individual ones. And they've been, this has actually spawned several clinical trials. We have, some of them are ongoing, but we've really seen that the combination of these PD-1 inhibitors with some of the viruses, the one that's actually approved right now is called TVEC. They seem to work pretty well for patients with melanoma. We're currently exploring some of these viruses also in other cancer types. We have a CRI-sponsored clinical trial that's coming up, and we're going to give one of such viruses intraperitoneally for patients with ovarian cancer in combination with a PD-L1 blockade. So this trial is about to open. We have already received an IRB approval at MSK. It's going to be a multi-center study. But my further research is really sort of delving into the mechanisms of how the combinations of such therapies work, and hopefully it could be applied, again, not just to melanoma, but to many other cancer types.
It's very interesting. It's another way about how checkpoint inhibitors are sort of giving new life to older therapies. Yeah. Dr. Vonderheide.
Well, I would just add that in this era of checkpoint therapies, PD-1, CTLA-4, and yesterday, for example, FDA just approved these drugs for liver cancer, gastric, stomach cancer, certain type of esophageal cancer. I mean, it just seems like every type of tumor. I study pancreas cancer where there is no immune therapy approved, with this one rare exception of patients who have that genetic finding. It's like 1% or less. And I think the avenue of research that we're trying to understand is, and we're kind of coming to the conclusion, as have many other people, that checkpoint therapy depends on your immune system having gone some distance toward attacking the cancer to form an immune response, to make these T cells, and then they get stalled out, they get exhausted. And they're parked there sometimes in the tumor, and they're just not doing anything. And we give them these checkpoint therapies, and they get a new life, and off they go. So if that's true, that means that the only patients largely who will respond are those who are sort of poised to respond. But as we're learning more about pancreas cancer and many other types of cancer, there's just no T cells there. There hasn't been a good response. The immune system just hasn't done even its fair share of the job. And that's where I think the horizon is. What can we do to generate those T cells and help that portion of the equation? And once they're there, prevent them from getting exhausted by all these therapies we know about. This is exactly what Leena was talking about in the introductory comments. That suddenly we're back to considering vaccination. It was one of the first things that was tried in this field. Didn't really work. Now we know why, because the cells that were made became exhausted. Now we have a fix for that. So now I think things are squarely back to vaccination, broadly interpreted. Radiation is a vaccine. Viruses act as a vaccine in a way. There's many other ways, and we could actually make true vaccines. And then there's ways to now target the cancer cell. And I think we now have the possibility of having both, which we've always wanted. We need a vaccine, and we need this way to boost those T cells once made to make them. And I think that's an avenue of research that's going forward, is various ways to combine these two distinct modalities to get synergy, just like Dmitriy was talking.
Well, thank you very much. And are you doing specific studies actually about how do you bring T cells into pancreatic?
Right. So if I could once again give a shout out to CRI, who, I mean, they paid for the stage, right? In collaboration with the Parker Institute for Cancer Immunotherapy, we did launch a trial that is, and announced it this week, that uses 4 drugs. And it gets kind of complicated, but I think it's worth thinking about where this came from. So it's standard chemotherapy, and that's to kill cancer cells and release those antigens. Get the cancer, prevent it from hiding. Get those antigens, and that's a fuel for the vaccine. And then we give an antibody against a pathway called CD40, which is a sort of a light switch on the frontline immune cells that work together with that antigen and actually start a vaccine. So those 3 things we've shown as a vaccine. That's great. That's not enough in pancreas cancer. Now those cells will just get exhausted, so now we add, at the same time, anti-PD-1. So it's 4 drugs. It's kind of nuts, really, when you think about it, 4 drugs. But 2 of them are already FDA approved for pancreas cancer, and 1 of them is FDA approved for many other types of cancer. It's just this one drug that is an activating antibody, which represents something novel. So the antibodies that we're giving, by and large, are blocking antibodies. We call them checkpoints and checkpoint blockade, and that's the sort of language. But I think the way to step on the gas is to use antibodies that are agonistic. They cause a signal to happen. They don't block one. And that's what CD40 represents. And it's not binding the tumor. It's not binding the T cells, but a whole other immune cell that is critical to get these vaccine responses. So it's a crazy idea. It's very complicated. Talked to Jill. Could you help us out? And she said it's actually a brilliant idea. And the trial started. And I think it's novel, and it represents a type of trial, many of which are now out there, of combination trials to get those T cells made and then keep them from being exhausted.
Great. It's very exciting work, I think, all around. Maybe we could open up this forum to questions from the audience as well.
So are there microphones?
Oh, sorry. I think there are microphones coming around to you.
Hi, I just have one question. Do certain chemotherapies that a patient might have already had preclude them from entering some clinical trials? Is it a good idea to speak with your oncologist when you're starting a new therapy to see whether moving forward that will preclude you from other trials? I've been told that was so, but nobody mentioned it, so I just want to clarify that.
It's a very good question, and I think historically many clinical trials which were generic in what they were looking at. So, for instance, phase 1 trials are often looking at safety and dose, and had very generic types of qualifying criteria, including that you could not have had more than X number of treatments, because we worry that might not be a safe or valid test in a patient who might be sicker or might be more exposed to other therapies, and we wouldn't be able to get information about how well the drug works. I think that is a little different now in this era of immunotherapy because many of the drugs we're testing are really immunotherapy agents. So chemotherapies may or may not have any impact on your ability to respond to immunotherapies. I think it is always a good idea to talk to your doctor about each step of the plans that you make, therapeutic plans, as to this is the step I'm thinking about now. What about steps for the future? And does this impact in any way? And is this a good idea to be starting this first? Or as we were talking about, maybe clinical trials could be thought of first too. I think Dr. Vonderheide alluded to the fact that there's some, I think still emerging evidence that maybe using immunotherapies earlier on might actually impact your chance of benefit from subsequent chemotherapies. So these are all active areas of research, and it's worth having those discussions each step along the way of your course of cancer.
Especially, I think, if you have a metastatic cancer, that's not curable at this point anyway, where you're looking at whatever your lifetime is of being in some kind of treatment.
Right.
I think in those cases, maybe not specifically for the immunotherapy trials, but there are other trials as well. So you might be precluded if you use one thing from moving forward into something else.
It's will you burn a bridge by taking this therapy and then, now I'm ineligible. And, that's the downside, that's one of the downsides to clinical trials is that there's eligibility criteria and exclusion criteria, something that doesn't feel right.
Right. Just something for patients to be aware of.
Absolutely. I think it's a great point. When we survey our patients and those who go on trials or those who don't, being ineligible is sometimes, but actually not for these types of reasons, is sometimes the reason. The number one reason a patient can't go on a clinical trial is geography. Actually, they live too far away
from a treatment.
From where this is, I think, maybe even a bigger problem. But I think you raise a super good point and really demands good communication between the patient and the doctor, not about the next step, but about the next 5 steps. Get a whole strategy.
Thank you.
Other questions? Yes.
I'm going to ask a real targeted question, specific. So you guys had mentioned that there are trials now using conventional chemo along with the new, checkpoint inhibitors. I'm specifically going to talk about colon. I know colon has had many negatives with immunotherapy. There have been a lot of immunotherapies tried that haven't really showed much benefit. Do any of you know of a trial that is ongoing with chemo as well as the MMR proficient tumors now? I know the MMR deficient have had good success, but I know there's some work in Germany. But does anybody have any ideas about that?
I will tell you honestly, I don't know of specific trials, but I do know there are ongoing trials of exactly that, as you say. And navigating clinical trials, where they're going on, what is the best trial for different scenarios, is something that actually can be quite challenging. Because even as investigators, if we're not personally involved in the trial, we may not be able to tell you if that's available. Is it a good option for you? Is it worth traveling for? But I do think that is a starting point, is a good conversation to have with your doctor to give you some guidance about that. I don't know if any of you would want to comment about investigations in this specific area at your own institutions or more broadly.
I'll just mention briefly because this came up. So colon cancer is one of those cancers where this MMR, which is mismatch repair deficient type of thinking, kind of really started to emerge because a certain percentage of colon cancer patients will have a lot of mutations because they have deficiency in mismatch repair proteins. Now, what we know about this whole concept of likelihood to benefit from immune therapy versus not in this MMR colon story is about single agent PD-1 or PD-L1, that type of approach. It's really one single kind of immune therapy approach. So our hope is that for patients who are MMR proficient or who may not be as likely to benefit from single agent PD-1, that they do have opportunities to benefit with various different combinations. And for sure, for patients with colon cancer that have retention of all of their mismatch repair proteins, there are plenty of clinical trials, at least at Memorial Sloan Kettering, which I could speak to because I'm not a colon cancer oncologist, but in our phase 1 group that Dr. Zamarin and I work in, there are plenty of trials that are available for these groups of patients for combinations of immune therapy drugs. I'm not aware of chemo plus immune therapy combination specifically, but that might just be because I'm a melanoma oncologist primarily. But the message I would say is, if you have colon cancer and you're MMR proficient, it doesn't mean immune therapy is not going to work. It just means you may want to try to find a combination clinical trial that might be more likely to benefit than a single agent PD-1 or PD-L1 drug.
And those are ongoing, so there's
many ongoing combinations for MMR proficient colorectal cancer.
I think a bigger point is that chemotherapy and immune therapy had been initially considered just oil and water. No way, we can't do it. I think actually in lung cancer we're seeing, and again this is data coming out in the last week and this year, that you can achieve major impact by combining chemotherapy with immune therapy, or give chemotherapy, radiotherapy first, and then come in with immune therapy. These are combinations that I think maybe 5 years ago we didn't think would actually be achievable, and now we see that they are. This will inspire these types of trials in colon cancer, pancreas cancer, prostate cancer, so on and so forth, I think.
Right. I mean, I will say that in lung cancer, the combination of chemotherapy and immunotherapy is actually already approved. Some of us feel that was very rapid, actually, that approval, because we're still learning more about how they work together. But what we certainly have seen, which Dr. Vonderheide alluded to, which we weren't sure about, was that they can be safely given together without necessarily increasing the risk for side effects, and that there really can be impact, which we had actually hoped that there would be. Just like viruses, radiation, chemotherapy could be a vaccine in a way of basically stimulating an immune response. And the trials that have been done to date in lung cancer, there are two quite promising trials. One was actually looking at the straight combination in metastatic cancer patients, which did lead to an improved length of time of keeping the cancer under control. There's also studies, as Dr. Vonderheide alluded to, of giving earlier stage patients chemotherapy and radiation, and then trying to sort of consolidate a long-term immunity, perhaps, with the addition of immunotherapy. And we are seeing, again, longer-term cancer control. We're still, these trials are still early on. We're hoping they're also going to translate into long-term survival, improved cure. But these are very much ongoing studies in all cancer types, not just in lung cancer.
I just want to add something, I think probably more relevant to how do you look for a clinical trial. And one of the things I want to emphasize is you should not look for a clinical trial at the time, unless your doctor is obviously participating in the study. You should not look for the trial at the time that you need to make the next treatment decision. It's always good to look in advance, especially if you're going to a different center. One of the problems that we're seeing is a patient, let's say, progresses on a standard chemotherapy. They go on the clinicaltrials.gov, they find that there's a specific study that's open at Memorial Sloan Kettering or University of Pennsylvania. They call. First of all, just because the trial is open doesn't mean that there are spots. But let's say there are spots. It takes them a couple of weeks to get an appointment. You get an appointment with the doctor. You may need to be referred to a phase 1 clinic within the same institution. Even if you're eligible and you sign consent, it takes 2 extra weeks to complete what we call a screening process. So now it's the patient that has been without any effective therapy for a month to 6 weeks, and they may be getting too sick from their cancer, and maybe that's not the appropriate time then to start on a clinical trial. So I always encourage patients to look for trials earlier, to seek a consultation in a trial center, so they know you. So basically, when it's time for you to pursue your next therapy, you can just call the doctor and say, hey, is there any trial that's open right now? Can you see me within a period of a few days so I can explore my options? And those are the patients that's much easier for us to get onto these studies, because by the time we get the records and see the patient and go through everything, as I have mentioned, it might not be the appropriate time to get into these sorts of discussions. Yeah.
There's questions way over here. Okay.
Hi. What's the source of the controversy with side effects for immunotherapy? Just from the few examples you cited, it sounds milder, if not the same, as with chemotherapy. Or, these side effects, you could get it from over-the-counter drugs.
So the controversy so the question is a good one about what's this discussion about side effects from immune therapy, and side effects happen with other kinds of treatments too, including over-the-counter drugs, and that's absolutely correct. So the controversy, I think, when I was mentioning before, to be very clear, is specifically around the question of, is there an association between the development of side effects and better outcomes with immune therapy? That's a bit debatable. There is no question that there are a number of studies that have been done where patients were randomized to getting chemotherapy versus getting immune therapy. And actually, it's very remarkable that the side effects in many of those contexts, at least with PD-1 or PD-L1 drugs, were less with immune therapy than they were with the chemotherapy group. Now, there are combinations of immune therapies that do cause side effects that are more so than single-agent PD-1 or PD-L1 drugs, and that can be problematic in certain contexts, and doctors and patients need to be aware of what those possibilities are. So I think that there's not too much of a controversy. I think we're aware that immune therapy can cause side effects, yet it can have great benefit, and the trick is to try to minimize side effects by working closely with the doctor and nurse care team, being open with communication, and really being clear in terms of how best do we maintain supportive care through these types of immune therapy approaches. But absolutely right, there are side effects that can happen. Thankfully, in some contexts, they don't seem to be as bad as chemotherapy, but there are some immune therapy drugs and different combinations that can cause more side effects, and so being mindful of that is important.
And I'd just like to add that these are not just side effects, but they're risks. And while the side effects from chemotherapy are usually reversible within a period of a week, a couple of weeks once the chemotherapy is washed out from the system, some of the side effects from immunotherapies can be lasting. They can last for periods of weeks or even months, and some patients need to be on long-term steroids for these things. So I think that's been sort of the main concern. It is true that this is the number of patients that get side effects from the immunotherapies is probably low. Significant side effects from immunotherapy is probably lower than the ones they get from chemotherapy, but the potential for them to be more durable type of side effects, again, from this lasting damage that the immune cells cause upon the normal tissues, that can be problematic. Yeah.
Hi. Since immunotherapy is emerging as a real focus and more important focus, how do the pool of potential patients keep up with the need, and especially if a lot of people have already had treatments that exclude them?
We have to be smart with our clinical trials such that there is only a limited number of patients that are available to help answer all the questions that are in the field. And this is where we're very grateful for patients who are able to come and participate in clinical trials, but there are more questions than there are opportunities to answer them with our available trial landscape. And so as we're developing clinical trials, it's very important that we're trying to be mindful of asking different questions with our drugs and different scientific questions. And there has been some discussion in the field of so much enthusiasm in immune therapy now that there are some similar scientific questions that are being answered and asked in different ways, and we have to be sensitive to that. And how do we really prioritize what are the most important questions, and how do we prioritize which trials, and how do we design the trials in a statistical way to get the answers that we need with as few patients as possible? These types of questions are important. I don't know if I have a very good answer, but this is an ongoing problem of the research enterprise right now.
But I just wanted to come back to something that Dr. Vonderheide had mentioned, which is that historically, very, very few patients actually participate in clinical trials. And in part, I think that was because we didn't have very good therapies to be considered. I think that's really changed in the era of immunotherapy. And I, as somebody who's worked in phase 1 clinical trials for many years, have really seen a change in the number of patients who actually are very interested in participating in clinical trials. And it's been a benefit for all of us in advancing research and care because of that. So I'm hoping that those numbers, those small statistics of 4%, 5% are really going to change. And I think there's also better efforts. Many more smaller centers are doing clinical trials. There's lots of opportunities, I think, to move things forward. Yes.
Hi, my name is Edwin. What about the men that have aggressive, like stage 4 prostate cancer, and they go on a treatment? And if their PSA is high, then the doctor says it goes low. Then he'll say take some medication, get Zytiga. Then after you take the Zytiga, it's like, can someone still do the immunotherapy while taking Zytiga? Because when someone takes the Zytiga, they're taking the prednisone. Now, sometimes someone says, if you're taking Zytiga or other medication, you do immunotherapy, it can cause death. Is it true or it's not? And then is it a long term if the immunotherapy you take? Is it a long term or is it work until it's cleared? And if it's not cleared, what's the next step? The other thing is, what about the people who are getting the patients that are getting the correct drugs and the ones that are not? Like you said, everybody's getting the correct drugs now. They're not getting any artificial drugs.
Does anybody want to?
Good questions.
I think these are all really important questions you're asking, and the answer is different, probably in different contexts. But I think, and any of you can feel free to chime in because prostate cancer is not my field of expertise. But for hormonal therapy in prostate cancer, actually many trials factor that into the development and incorporate hormonal therapy as part of those clinical trials. And I think that's true even in the context of immunotherapy. Immunotherapies in prostate cancer is an active area of exploration. There are many ongoing trials. In fact, there is some history of immunotherapy in prostate cancer. One of the few vaccines that is approved in prostate cancer. And I think there's a lot of studies going on. That is something to talk with your doctor about. And if your doctor is really not involved in clinical trials, even seek a consultation where you can actually discuss some of those issues. Because I do think there are opportunities for all these different scenarios that you suggest. And I think there's potential promise in immunotherapy that's still relatively early on in prostate cancer compared to some of the cancers where we've been studying these drugs for longer, melanoma and lung cancer. There's a lot of emerging opportunities in other cancers.
Yeah, I do talk to my doctor, but the second time, I like to look at a second opinion. If while taking the medication, can an immunotherapy also be done?
So many of the trials will, if you're already receiving some active type of treatment, the trial will probably exclude you from participating. Normally, most of the trials.
It's not a trial.
Yeah,
Actually.
Oh, you mean like if you didn't want to receive it on the trial, but let's say if you're receiving Zytiga with prednisone and you wanted to add like an immunotherapy drug to it, is that your question?
Right.
So the drug is not approved for prostate cancer. Technically, the only way you can get that drug in combination, it's if there is that sort of a trial that's currently ongoing to test that combination in prostate cancer. The drugs are expensive. Yes, you can buy the drug, which is many, many thousands of dollars per dose. And again, the benefit is not proven. And we also don't know how Zytiga with prednisone would interact with immunotherapy. It may work, it might not work. It may give you very severe side effects that we would not necessarily predict with either of the drugs alone. So typically we don't encourage these sorts of combinations just given on an off-label kind of a use, what we call. We typically encourage the patients to explore this more within the context of a study where this is done in a controlled kind of a setting and following appropriate guidelines.
So you're saying immunotherapy is not good for someone with stage 4 aggressive that's already going into your...
Oh, no, I'm not saying that. And in fact, there is some data with immune therapies being effective in prostate cancer. What I'm basically saying is that if you are on an active therapy that's working, you can continue to receive that active therapy. But if that therapy stops working, you should not seek and add something to that active therapy or something experimental just because you think that this experimental thing, it will work. Unless, of course, again, like I said, there is a trial specifically for patients that were on Zytiga, for example, and have failed it, and the trial is exploring a new combination. I'm never going to say that this is not going to work for stage 4 prostate cancer because Just as we heard, there are some vaccines that, one of the first immunotherapies that was approved was actually in prostate cancer that did demonstrate some benefit, and there are other studies that are ongoing.
We have a
Thank
question
you.
on this side.
Yep, over here.
My question is about immunotherapy. How long do you have to have autoimmune diseases under control? And if you have them under control, are you ever eligible for autoimmune therapy, such autoimmune diseases such as ulcerative colitis and ankylosing spondylosis?
Yeah, that's a good question. You want to?
Sure. So it's a very important question. Just to rephrase, what happens when a patient with perhaps a lifetime history or number-year history of an autoimmune disorder also develops cancer and is being considered for either clinical trials or even standard of care immune therapy drugs in the context of an underlying autoimmune disease? In terms of clinical trials, each trial words the language a little bit differently in terms of what may be relevant for inclusion or exclusion and eligibility for these trials. Some allow certain well-controlled autoimmune diseases on very minimal immunosuppression or no immunosuppression, and so the details of that are dependent upon each individual clinical trial. I do think it's a little bit of a challenge many times because a lot of trials unfortunately do exclude patients with significant autoimmune diseases, and so we really don't know what happens in these contexts when these patients need immune therapy and have an underlying autoimmune disease. What happens to those patients? So each trial would be worth looking into the very excruciating details of each trial on a trial-by-trial basis in this kind of situation. Outside of clinical trials, it's a real discussion about the risks and benefits of an autoimmune disease and the stage or situation with the cancer in terms of what could be the benefits of taking an immune therapy approach versus not, or what are the other options that exist, and what are the risks of potential autoimmune diseases getting worse with immune therapy. In melanoma, there have been a number of publications, and we've treated a lot of patients now with autoimmune diseases that also have metastatic melanoma with immune therapy drugs. Some of those patients have had worsening of their underlying autoimmune disease, but some have not. Some of those patients have had other side effects related to immune therapy, some have not. Patients have had benefit with immune therapy against their cancer, even with autoimmune disease. So, in my opinion, outside of clinical trials, an autoimmune disease in and of itself is not necessarily an automatic exclusion from an opportunity to try an immune therapy approach. It may be something where you just have to think about the risks and potential benefits and alternatives a little bit more carefully with the treating team. But in my opinion, when patients have cancer that would really potentially benefit from immune therapy, I wouldn't want necessarily an autoimmune disease to completely get in the way of that, although it is something we have to consider carefully.
That's all the time that we have for this session. I'd like to please thank all of our experts for joining us.